I'm very proud to be part of this in a kind of larger sense. It grew out of some things that we started under COVID a couple of years ago, as we were really thinking about what it meant to address health equity at a time of crisis. Right? What does it mean for health professionals and other people that are trying to support health professionals address all of these issues at the same time? Bread of Life has been around since 1992. And we'll hear a little bit about that kind of history. They had a very agile approach to what their mission was that allowed them to think a little bit more deeply about what in the previous models of approaching health equity was working and what wasn't working. And I think that really stepped forward to embrace a sense of community health workers as strength-based mechanisms for creating change. And this partnership is about trying to see what that would scale like. So as a first effort to scale a strengths-based approach to health equity in the Houston area, with Bread of Life playing a central role as a kind of hub for other efforts coming around it. Is that fair enough? Mm-hmm. And so Gabriela Martinez worked for us. So you got your CHW certification too, or did you?
No.
You never did. So you worked for us at CHWI for a while, and very happy to have you here. You're going to speak a little bit. You're the assistant director right now for the Quest. Which one?
Bread of Life Academy.
Bread of Life Academy. Yeah. And then Morgan Rasmus is Dr. Morgan Rasmus is the director for the Bread of Life Academy and also the director of innovation for Bread of Life. And Monica Espinoza is a community health worker who's gone through our program and also been at Bread of Life for 3 years now. So one of the kind of superstars of the CHW kind of community health worker activities that we have. And then Dr. Sarah Simmons is a good friend and there's not helping. Okay, sorry. Dr. Sarah Simmons is a medical doctor from Houston and is the director of health outcomes for Bread of Life and the person who oversees all of these activities. So is there anything I forgot?
Yeah.
Thank you very much for coming. I think that the big idea is that we'll have a few questions for me and kind of get us started, talk about the kind of things that people are doing. And I think that the big idea is that if you have questions, we can respond to them. And part of the reason that that's the big idea is that we want to really understand how you can be responsive as opposed to being top down and saying these are the types of things you're doing. And so when you do a strengths-based approach, it's kind of an odd first step. You say, I don't know. You need to ask me some questions so that I can respond appropriately to what your situation is. You don't say, here are the answers. Choose from my menu of answers what fits you. So perhaps we can start with a little bit of history of Bread of Life. Morgan, would you like to do that?
So Bread of Life started 30 years ago, as Dr. Dad mentioned, in 1992. It started originally with our founders, Pastor Rudy and Pastor Juanita, pastoring the church that's connected to Bread of Life, and getting there and finding lots of unsheltered people sleeping around the building at the time. And it was shortly after, I guess, Desert Storm would have been around then. So there were quite a few unsheltered veterans who were making their home in downtown Houston. And so we started with over 500 hot meals, 7 days a week, about 3 times a day. That's what we started with. That was the need then. As that need changed and Houston changed their direction in housing unsheltered people, we moved into housing and case management and providing doctors. So we had a clinic on site for about 10, 15 years. There was a clinic on site with an OBGYN, primary care physician, and dentists, and case managers who would come in and out and care for unsheltered people or people who didn't have access to health insurance or health needs. And then as that changed, and there became more federally qualified health centers in Houston that served that population, we started looking at how we could better support the community in other ways. So we did housing through our partnership and organization called Seminoles Community Development Corporation. And now,
interrupt you right there. Just if anyone was at the Hitch Talk 2 days ago, Raina talked about Timonids because Raina was working in Timonids.
Yes.
Absolutely. Thanks for sending one of these pictures.
Yes, she is. So now what we do though, primarily we have 4 kind of pillars, correct? So we restore communities through our community monthly community distribution. So on first Saturday, we have a food only distribution from 10 to noon at our downtown location. And then on third Saturday, we have a food and household supply distribution from 8 to noon. That's that. Yeah, that's our community health worker team, which Monica can tell you more about. What else do we do now? We also have a community radio station. So through Inspiring Communities, there we go. It only works inside of 610. You can download the app if you want to hear it outside of 610, but they do various topics on health, equity, all types of things. And then Sustaining Communities is Dr. Sarah in the area. Yes, and then the education part is Gabby and I, and we currently run an academy where people can get certified in phlebotomy, community health worker, in partnership with U of H, and Cisco certified networking administrator. Our target demographic for that academy are people who've had foster care experience, aged out of foster care, or had juvenile justice experience. So creating equity in employment and certification education pathways. So that's just a brief history.
Yeah, great. And did you have an idea of how you're going to pass it, or?
No.
Sarah, would you like to talk a little bit about your specific vision for the partnership?
Sure. So as Dan said, our health outcomes program started in the middle of COVID, and we had a project where we worked on an equitable vaccine initiative. So through the Rockefeller Foundation, we partnered with U of H and Dan's Community Health Worker Initiative. And if you guys remember at the beginning of the pandemic, it was hard to find vaccines. Do you remember that time when you wanted to get one, but you couldn't find an appointment anywhere? And it was especially hard for people that lived in vulnerable communities, areas without transportation, socioeconomic disadvantaged populations. And so our community health workers helped to find access to those vaccines. If you remember in the pandemic, the issue became not so much access, it became information and what we could trust. And so again, our community health workers worked on giving good information, building those trusting relationships. But as you can guess, when we look at things like vaccine inequity, we see things like much broader inequities and health inequity. And so our community health workers worked a lot on what we call the social determinants of health. Are y'all familiar with social determinants of health? So that's kind of my passion. That's what I'm huge in. 70% of our health is determined by things that happen outside of the doctor's office. And as Dan said, I spent my previous life, as a family medicine physician. And there's a great quote from a book called The Health Gap that I like to kind of describes my transition. But it basically says, why do we keep treating things when we keep sending patients back out into the conditions that cause their illness? Which is why I made the transition into public health and community health. And so what we do is we focus on, through this program, on helping clients identify their social determinant of health barriers, letting them set their own goals, and then helping them work towards those goals of overcoming maybe what's keeping them from that next step in health. So that's a lot of words to say. I won't go into all the details, but this project that we're currently working on, the Healthy Houston Collective, has a lot of different arms, but basically our goal is those social determinants of health. So we do that in a lot of different ways. We have community health worker teams at clinics around the city where people may enter. We have community health workers at distribution. I'll let Monica talk about that and how she interacts with clients. We have the academy. And then we also have some other sub-granting partnerships. So Dan and the University of Houston have been nice enough to help us. We work together. Our goal is really, how do we create this broader, sustainable change? So I always say, I want to work myself out of a job. I want to create a place where you don't need us, and that all these things, these resources, this access is just there. Obviously, we're a long way from that. Maybe we never will be, but that's kind of what our goal is.
That's great. And so, Monica, do you want to take that over and give us a couple of examples, like for the distribution? Talk about what that happens there.
Okay, so every third Saturday, what we do, we register all the cars that are lined up. And what we do, we ask for them for their ID, and we have a form. We have a couple of questions that we ask from them. And then that's how yeah.
But why does the distribution exist? Who are you serving?
Oh, we're serving the low income.
And why is it community health worker?
Oh, we help them find those resources. So the way we connect with them, we have a form and we make those calls to the people that are in need. Because there's resources out here that they don't know about. And also the biggest barrier is their language and their transportation. And also what we do, we help them, like, for example, if they don't know where to go, they don't know what to translate, we're here at, sorry, I'm nervous. So you hear me? Okay, so there's this mother, she's a single mother, and she has a 16-year-old, and she's looking for housing. So that's another biggest barrier. There's a lot of people that are suffering from mental health, housing, and she was living in her car, but we were able to find her somewhere to stay with her 16-year-old. And also we helped her with clothes, with food. So I enjoy doing that. I enjoy helping those who are in need or whoever that need help with. So,
I mean, thank you for doing it. It's
Yeah.
inspiring. So, just to say it out loud, a lot of the time, people don't know what resources are available. They end up sleeping in a car. When an apartment could be made available, they do qualify. Closing those gaps is one of the main things CA studies can do. Gabby, I wonder if you would say a little bit about your target audience with the Academy.
Cool. So what the Academy does, again, like Dr. Morgan said, the target audience is anybody who has experience with the foster care system or any juvenile justice system or anything prolonged, And so the goal is, they're in the system for so long and coming out and expected to just know adulthood right off the bat. And so what our goal is, assist in things like life prep, adulting 101, because even as adults, we still don't know what we're doing sometimes. And, guiding them towards, those sorts of support systems and, showing them at least these first steps in career, like these are the kind of ideas that you can get into. This is just building that foundation first before, just sending them off into the world. And like Dr. Maureen said, we have a phlebotomy course, a community health worker course, and a Cisco IT networking course. And, being able to also provide whatever we can through Better Life, through our wraparound services.
Tell us about strengths-based. What makes it strengths-based?
That's a good question. So just because we identified that as a target population, we don't limit them to just that. About 1,200 young people age out of foster care in the state of Texas every year. Most will end up unsheltered and underemployed, if employed at all. And so we don't approach it from that direction. We just approach it as though they're a normal 18-year-old who's about to go to college, right? Because what you also have to think about too with foster care is if you've been in foster care and you age out of foster care, you've most likely gone to at least 16 schools at minimum, depending on how long you were in foster care. And so that affects what you're able to do, because if you can't get your high school transcript, you're not necessarily going to be able to access the free college resource that Texas offers for aging out of foster care if you've been in several different schools in several different districts because of the way the foster care system works. So what we really try to do is just approach it as though hey, look, like Gabby said,
adulting is hard at any age. Like I'm 35 years old and there's still stuff I still don't know how to do or have to like Google and ask somebody like, hey, like, how do you do this? And so we just approach like your regular 18-year-old or regular 20-year-old who's just starting out, right? You just graduate from high school and you're trying to become this adult, but recognizing that it takes more than um, just knowing like your social security number, like, do you have an ID? Do you have an address? Do you have a house to live in? Like just starting at those basic levels, but also just approaching it like, okay, what would you actually love to do outside of the body, right? Those things that we who have been able to go to college are able to do where we're able to dream a little bigger. So that's kind of what makes it more structured.
So to add to that in your strengths-based question, Dan, you know, so many of the clients that we work with, and specifically this demographic, but really all of our clients, they've spent so much of their life kind of falling through the gaps, being unseen, being told that they don't have the right qualifications or the right identification or the right setup. And so a strengths-based approach is basically helping them to, number one, recognize what their abilities are, what their options are, and helping them learn to set goals for themselves, which sounds like you guys are all here in an honors college setting. I'm imagining you don't have any trouble setting goals for yourself. There's a lot of people that don't necessarily think past where am I going to eat tonight, right? And so helping people develop that, like if you could be anything you wanted to be, what would that look like? And starting there and then helping them work backwards to gather those building blocks and those resources. And the last thing that I wanted to add that I think is important that we haven't said is that what's so special, I think, specifically about the Community Health Worker Initiative here, and that we've tried to model and work with as well, like I'm going to be really candid. If I come and tell you what you need to do, like I'm the old white lady doctor in the room, probably not going to listen to me. You're going to smile and nod, and then you're going to go back and do what you were doing before, right? If you can find someone that you can relate to that has a similar experience, speaks a similar language, is learning to adult, Gabby's doing a great job, by the way. There's just a different level of connection. So it's really important that our community health workers have that understanding and that lived experience, because that perspective is so important in the relationship building.
You said 2 words about why that's equity. What is the strengths-based approach?
Like actually to
Why is equity? I'll give you 4.
So does everybody understand kind of the difference between equality and equity, right? So, we're starting and we're working to get everybody up to the same level. And not everybody has had the same experiences. They don't have the same options and the same behaviors. And so what we do is try and help fill in those gaps, try and create a support system for them, try and be an advocate for them and walk with them, so that they can get to that point to be independent and on the same level to be able to make those same decisions. Does that answer your question?
Yes. Dignity, it's a sense of self, right? All those good things that go. Can I open it up for questions from Michelle?
So I have a question, and that is, tell us, if you don't mind, a little bit about Bread of Life. I mean, what is it? A church? Is it a community group? Is it? Sorry.
So we are a 501c3. So we were founded by a church community. So we are faith adjacent, but not faith based. So we are a complete 501c3 secular organization. We just happen to share the same buildings. But yeah, so we're a 501c3 nonprofit.
With that famous.
Yeah, we have a famous benefactor. Yeah, I do. Okay. So some of our funding does come from Be Good. Beyonce knows this foundation, so she and her family grew up at the church that founded Bread of Life. Any other questions?
You mentioned at the beginning that you're scaling up the effort. Can you talk a little bit about what that would mean, and what some of the challenges are potentially going to be to scaling up this type of work?
Yeah, absolutely. So,
2 words.
yes. Um, so we're scaling up in the fact that, number one, we want to, and Dan and I can talk about this for way too long, so I'm trying to choose my words wisely. We're trying to scale up in the sense that we want to meet people wherever they are, right? So wherever they live, they work, they worship, they go to school. We want to be kind of that front door for them. And so scaling up right now looks like us expanding where our community health workers are around the city. So again, like I said earlier, we're in a few clinics. We'll be doing some more community outreach. There's a new building called the Navigation Center, which is a transitional housing facility. So as the city closes homeless encampments, they move those unsheltered folks to this transition period for 30 to 60 days until they can find permanent housing for them. And our community health workers are there in the Navigation Center helping them with those steps. So that's what scaling up looks like. It looks like finding any and all entry points, right? And making it as easy as possible, easy to access. Why is that hard? Houston is a very big city. Nonprofits in general, and this is not just based in Houston, but tend to work very much in silos. And it's not because it's a competitive thing. It's just because you get so focused on your work and your lane that it's hard to see what else is out there. And so building those partners and those networks and those relationships of trust and collaboration between maybe entities that have different priorities, right? So the clinics that we work at don't necessarily, yes, we all want to see health equity, but they need to see patients in a set amount of time and get people through and get them better, right? So they have kind of a different priority maybe than we would. And so working to meet both of those priorities and align things together is probably our biggest challenge.
So one of the other things we did recently with the city of Houston in partnership with them is basically kind of restarted how Better Life originally started. So every Monday, Wednesday, Friday, and Sunday evening, Better Life in partnership with the city provides a hot meal to unsheltered people at an old police station downtown. And it's a very dignified experience. Like there's tables, tablecloths, a food truck partners with us to do it, and we have a community health worker place there too.
So just to add a little bit of inside baseball, money is needed to scale. And in order to ask for the money, we need to be able to prove that there's something like return on investment that's produced by these activities. I think that there's a lot of feel-good stories about CHWs doing this great work without ever being able to show how that return on investment works. And so one of the main things we want to do is say the community health workers and other people that are frontline workers who are properly trained and staffed and supported can create these beneficial feedback kind of loops where providing more information to people who are suffering silently because they don't know what's available is actually more of a return on investment than only responding to people who can recognize that they have a problem and recognize that you are the one who would address that problem. So if you think about the ecosystem of how resources are provided right now, they tend to be very much in those categories. You have people who don't see themselves as part of the categories or haven't fit into the categories. The CHWs who are out in the community are contacting people outside of the categories in both senses. And being outside of that category, I think, is a better business proposition for the nonprofits because you're actually more likely to be making the bigger change than the people that are more in need of that type of help. Then the model that we have now is more like a consumer model where someone knows, oh, I need this, I'll go buy this. It doesn't work that way in real life, right? And so getting that real life kind of ecosystem going where we can get better research, we'll understand better what the actual dynamics are for people who are trying to thrive, what's keeping them from flourishing in the place that they're at. And then having enough of the research to say, oh, look, that thriving actually helps people. That's part of our return on investment. It's people being happier and people doing better in their lives. Having people who come out of foster care not living on the streets, well, that's a good thing to begin with. But having them actually work with other people to keep them also off the street, that's a multiplier. That's that kind of virtuous feedback. Measuring that, making a case for that, showing that that could happen in all sorts of other nonprofits at the same time without getting in each other's way. That's the goals, I think.
I agree. And the money is often needed for it. So like there are other nonprofits who do similar work to us, but because the grant pool is so small, we're always basically competing against each other for the money. So what we've tried to do lately is be sub-grantees or giving our grant money to sub-grantees to make it a little bit more equitable too.
Oh, there's another question. So how do people that are aging, I want to ask you, how do you find people that are aging out of foster care? How do they know to go to Bread of Life? I mean, it's interesting. I'm just kind of curious as to how that all works.
So we currently partner with Collective Action for Youth. It's an advocacy organization here in Houston who works directly with young people who've aged out of foster care. We also partner with the Coalition for the Homeless and their youth homeless program. And so basically it's referrals. It's a lot harder than you think to find young people who have aged out of foster care who want to do something. It's a little scary, right? Because systems haven't necessarily been your friend along this journey. And so encouraging them and getting them to participate is a lot harder than it looks, but primarily strategic partnerships. So Collective Action for Youth is our main recruitment area, and then Coalition for the Homeless, their youth homeless apartment program. Yeah.
So I was really struck by the comment about the students not having access to the transcripts and transferring schools. I'm just curious, if I'm not sure who this question is for, to talk a little bit about the challenge around personal data and how that, just talk a little bit more about how that presents a barrier and what you all need to do to overcome that, and how it's addressed.
Yeah, so that's where our so we have for the academy what we call life prep advisors, but they're literally just community health workers. We just have a different name to kind of separate the two sections. But the barrier, not having access to your social security number or you can't get an ID, or your birth certificate, you can't get an ID. And to live somewhere, you have to have an ID to live somewhere, to get a job, like all of those things play a role in it. And by not having access to your personal data, it can be a lot harder. And sometimes just even knowing where to go to get those things, like I need to go to the Social Security office, but I don't know what to ask for. That type of thing is a barrier. I think Gabby can speak for today.
So yeah, so when it comes to like getting any of that personal information, there are outside resources, and it's just a lot of, trying to find, the ones you can connect to, and going kind of backtracking, going as far as like Social Security office. At one point, I did have a client that did not have a Social Security card, and this is always this constant back and forth. But it's a lot of connecting with the community health workers and having those life prep advisors to connect with and finding those outside resources. So it is possible, but it's just a lot of hunting.
I just want to make sure everyone understands, because this was a surprise to me, how broken the foster care system can be. You kind of expect it to work in some ways. And what would happen, someone turns 18 and
We're trying to record.
oh, sorry. Do you want to tell a little bit about that?
So basically when you turn 18, they're like, okay, here you go. So you do have the option of signing yourself back into care. However, depending on what your care experience was, you're probably not going to choose that. But like Abby was saying, it's you have to make a lot of phone calls, right? But if I'm trying to find somewhere to sleep tonight, figure out what I'm going to eat for lunch or dinner, my one meal today, calling the Social Security office to see when they're open to make an appointment isn't necessarily in your purview of, I have time for that, right? You're putting out your fires, your individual fires. And that's pretty much what we've seen so far is the people we've served so far through the academy is the ultimate goal is for them to not have to put out so many fires, right? We want them to look past today. But when the foster care adds a whole nother layer to it.
You would think the system would work, but unfortunately, the system isn't equitable, right? The majority of people in the foster care system are poor or Black and brown. And so if you've stayed in it your whole life or even a long portion of life and you end up aging out, you can sign back into care, but typically you're probably not going to choose that. So now you're just trying to figure it out day by day. And that whole system of having to call somebody and figure out where the Social Security office is, you need a birth certificate to get a Social Security card, you need to know your Social Security number to get a Social Security card, all those things that like your biological birth parents would know. You don't actually have contact with them or know where they are to even get that information, right? And depending on how swamped your case manager was, they might not have access to those records either. So
Yeah, but I just want to add, like, some of the things that surprised me. You got this picture, and it happens that you've got a foster parent who cares about you. That's not the normal situation. The normal situation is that you're in a group home and you barely have any relationship with the adult who's making money for providing bare meals. Then you come out of that not trusting any of the adults. You have a case manager who treats you in a very instrumental way sometimes, right? So you come out of it with lots of reasons to distrust that system. So having people who've gone through it, who can tell you what it means to make that transition, I think is very, very important.
and that distrust of that system affects that distrust of that system affects your trust with all the other systems you're going to encounter. So it affects retention rates for us. So like it's a lot of constant communication, like, hey, how are you doing? How the class is going? How is this working? Is this working for you? What could be better? And that individual relationship with life advisor and community health worker also helps. So it's really just surrounding people with a group of people who are supporting them along that way, because that distrust of that one system affects your whole entire experience for the rest of your life.
Monica, if you would say something about like the undocumented people that,
Like what?
like what kind of challenges do they face? So I think a lot of undergraduates don't really understand what kind of challenges people face.
The biggest challenge I've come is it's hard for them to get a job. So they don't have, like, they're looking to get like a green card, they don't have insurance. So we're there for them to help them find a process to get them like those a job, I'm sorry.
It's a process, right?
Yes. So no, I was just gonna add on to what she's saying. So many, right, of people that you see maybe out on the street corners. There's so many preconceived notions in our society about what that person is and why they made these choices or whatever it might be. But it really starts, not that every unsheltered person came out of foster care, but there are similar struggles that happen with things like that. And then once people are out, maybe they have a criminal past, right? Because they've been working to survive and they have trespassing charges. Girls or boys that are trafficked often have a criminal past. And so they don't necessarily want to go to the police station to get an ID, right? Why are you going to show up there? That's a place of trust issue. And especially Monica is bilingual. And so she works a lot of her population is immigrant population. And again, if they're not documented, there's a lot of, I want to stay under the radar. I don't want to do this. I don't want to talk to people. I don't want to share information. So it's not by choice, right? It's by the system. And then even when we look at unsheltered, when people are out there, one of the things that we're encountering, it's a different lifestyle and a different way to live. You can imagine maybe you find the love of your life. If you don't have an ID, do you really think you're going to go to a courthouse and get married? No. But that means that if you go to a shelter and you're not married, then the woman is have to go to that location and the man's going to have to go to that location because street marriage isn't recognized. Or maybe you have a pet, right? And that's the only living thing that you've ever been able to count on. And they tell you, well, we'll give you housing, but you got to take your dog to the pound. Well, there are lots of reasons, is my point, why people end up in those situations, and they tend to snowball the longer they're there. the more kind of barriers they encounter.
Please.
My first question is, there's a lot of what you've been talking about are both experienced by individuals or caused by politics. So I was wondering if you could talk about some of the policy causes and implications of your work. And then you mentioned earlier, and your title is outcomes. What are some of the outcomes, and I like data, but what are some of the outcomes that you all track? And what are some of the outcomes that you're maybe hoping to track in the future, or perhaps more resources for capacity?
Yeah, I mean, I'll start with that one. So the health outcomes, you know, again, we can talk about tracking specific health outcomes, specific rates of cancer, or specific controlled versus uncontrolled diabetes or high blood pressure. One of the big ones that we track right now is access and what we call patient medical homes. So connecting people with a primary care doctor that they know that they can go to, it's not the emergency room. And so that's one of the big main things. We are working with other clinics. One of our partners, Avenue 360, is a federally qualified health center in the city. And our CHWs there are working with people with chronic diseases to keep their appointments. So maybe you should see your doctor once every 2 weeks if you have uncontrolled blood pressure and you've been missing those appointments. Our community health worker then is going to you and saying, okay, what's making it difficult for you to make this appointment? Can you not get off work? Do you not have childcare or transportation? Do you not understand what uncontrolled blood pressure might mean for your future? And so they try and meet them where they are. And so it's a broad question right now. Really, we're really focused on access as our health outcome, and then knowing that those other things are going to follow. We are starting some projects specifically with breast cancer and prevention and screening. That's kind of our next step. And then Morgan, you want to speak about policy?
So it's interesting because I think Bread of Life is more like a grassroots organization, and we always have kind of seen ourselves that way. We're also not very large yet. I think we have maybe like 175 to 100 employees now. And we grew relatively quickly. So I think last summer we had maybe 50. Policy is hard. Okay, so we live in Texas and we live in America. And the people we serve are Black and brown for the most part, and mostly brown. And policy impacts them directly, even when we don't think about it. And so like that uncontrolled blood pressure, that uncontrolled diabetes is a systemic problem that has happened for generations and generations in their families, and they think it's normal. I'm an example of that. And so I think as we start to move into our future, we start to look more into how we can affect policy. However, I'm currently the only person who has any policy experience. So I'm not sure what that looks like in the future, honestly. I do hope that policy changes soon. But I think there's so much, I think for us, it's more of like that first line of like, we want people to just have access, just that direct access and the direct implication of like, okay, let's help you get this under control. Let's help you do this. I feel like policy requires more money too. So that's that part.
Opportunity for partnership.
Absolutely. And, you know, it's all tied together. So, you know, data really is what we do to help influence policy. So we're trying, you know, a lot of nonprofits, and it's not a bad thing because they are boots on the ground, people right in front of us. We just had a conversation about data like 2 days ago. We work really hard to record everything that we're doing in an honest way and make sure that we're keeping things accountable. And that's helping then to prove or disprove, you know, some types of further interventions and hopefully then eventually helping to influence policy.
Other questions? Students? Maria? Can you repeat the question into the microphone or go? Yeah.
Okay, I will repeat it. So you said you call people, right? mostly? What do you do with unsheltered or homeless people who don't have access to a phone?
We also have like, and on Saturday, we do have a station where there's walk-ups. So we do have community health workers there that, keep in touch with them. So that's how they. Good question.
Could you describe some of the obstacles that you faced dealing with how there's silos in your scenario?
Sure, I mean, a lot of it, you know. I hope it's not jaded to say, you know, it really, it comes down to funding and money, right? So if you're a small nonprofit organization, you definitely see we all work towards these goals. But, you know, if your funding is limited, you're going to use it for your endpoint and your goal. And so a lot of our work is wrapped around, yes, we're doing the boots on the ground, we're serving people, but we're also trying to build these community networks and partnerships. Number one, so we don't have to reinvent the wheel. We can send people to Coalition for the Homeless and they can do housing assessments. We don't necessarily have to do that ourselves. We just need to help build those bridges. So again, it's not that silos exist because everybody's kind of, you know, fighting and stay away from me. It's just that everybody is so wrapped up in their own cause and their own reason. But so many, I think you've probably heard, so many of these populations overlap: homelessness, trafficking, foster care, previous incarceration. All of these things kind of overlap. So you might see an organization that's focused on trafficking. Well, we're very likely serving the same people. And so that's what we kind of try to work together. Does that answer your question?
Just to follow up on that, just back to the data thing. I'm just curious, how do you coordinate information across these organizations that you partner with about requirements? Is it, I imagine there'd be all kinds of challenges.
Don't look at me.
That's a work in progress. It's a challenge. There are data systems out there, and some of them are not as user friendly as others. So it's a lot of collaboration. It's a lot of data sharing agreements. It's a lot of being aware and cognizant of HIPAA when we're talking about medical entities. And for education, yeah, as well. So, you know, to answer your question, it's not always pretty. It often looks like a lot of Google spreadsheets that we cut and paste from. But it is a work in progress. A lot of what we've spent kind of the initial part of our work doing is figuring out what data is important. What do we care about? We don't care about every number, and sometimes it's not numbers. A lot of it is qualitative and stories. And so figuring out what it is we want to capture is kind of step number one, and then figuring out the best way to do that and working together. My best answer is we figure it out on a case by case basis, but it probably doesn't look the same from, you know, partnership to partnership.
If I can just expand on that just a little bit, I think one of the places where Sarah's right, data helps policy, is local policy really matters. And especially if you think about the nonprofit space as a kind of ecosystem where people are trying to find the best way to answer a solution, the policy people at the local area could say stuff like, hey, here are some incentives for sharing data. This is what it means for you to be able to pass off a client and trust that that client will be taken care of at the next step. Those are things that are local policy. They become state policy when they work locally. Data is what supports the idea that that grows higher and higher as a path, because no one really wants it to be dysfunctional. There are different people who have kind of cynical reasons that they don't believe that charity works. And I think it's really important. We're not doing charity. We're doing this kind of strengths-based approach because we want to see flourishing, and having that flourishing happen. I think that that's something that only happens inside of an ecosystem. Doesn't happen individually. Making that point is hard on the data side because with data, you tend to only measure individuals. We're trying to figure out how to find those little pieces of data on individuals that indicate how they fit into an ecosystem. Getting collective impact stories, getting the sense for how it all ties together across multiple silos is a challenge, but it's doable. And it just, as that happens more and more, we think that the strengths-based approach will reinforce itself. We think that it will lead to real equity because when people are strong, they are able to get better outcomes. And when they're supported, they feel like they're getting the outcomes they deserve, not ignored by the system. When that starts happening, the system says, hey, this works. This worked in the responses from Bread of Life with the homeless and with the recently some people graduating from foster care. That should be a model that gets adopted in Dallas and then San Antonio and et cetera, and it becomes a statewide policy. So I think that there is a way in which it becomes at least conceivable that this small, very directed work, like Monica's talking about, one person at a time, somehow builds to concrete policy change. I don't know. I'm trying to just say the same thing you were saying.
No, that's great. That's great.
Other questions? Yes.
So you mentioned collective impact, and there's a couple of different models out there for like collective impact or network improving communities. Are you all working to build something like that in Houston? I know there's one in Dallas for education. There was one in Houston around really education that failed. But I feel like that's a path to bring partners together to scale, to agree on the problem, to agree on a set of solutions. And
Yeah.
scale work and then work together to get money.
Yeah, absolutely. That's definitely the goal of this Healthy Houston Collective and bringing all these kind of partners together. So we have, city county partners, we have academic partners like U of H, we have FQHC partners, the clinics, nonprofits, and we're working to kind of bring all of those together. So there are some kind of groups that are working together, the Health
Equity Collective.
Health Equity Collective, is one that is growing as well. But there's nothing right now that's kind of really strongly doing the work, but absolutely that's the direction that we're headed. That's kind of the goal.
Why'd the early childhood one fail?
I'm not 100% sure. I think there's some inside baseball
Okay.
to reference.
Yeah, there's a lot of inside baseball. I used to be a teacher.
Well, I mean, in terms of stakeholders and who was funding it, I didn't like the direction it was taking, and they weren't able to really come to a common definition and understanding of the problem.
Oh, I used to be a teacher, so I do remember that. Yeah, education is a really interesting experience, especially K through 12. But yeah, also like Dr. Sarah said, like there's a lot, we're doing that too, but I think what people tend to forget, there's a lot of really small nonprofits in Houston who are doing really great work, but they don't have access to we have name recognition because we've been around for so long. But without that name recognition, it's really hard to access those grant funds. So we have somebody who's on retainer who helps us write our grants. Most nonprofits, like the individual ones, can't afford that. So that also makes it a little harder.
Could you say a little bit about collective impact? I'm sure some of the students don't know it. I don't know if you want to, or what that model is. Or Virginia, you want to say what collective impact is?
You would say better.
Yeah, you should.
So collective impact is one model to try to bring together different stakeholders and different groups. In the case of education, which is why I work, for example, bringing together school districts, bringing together private providers of pre-K, tutoring, social services as well, to define a problem, to identify a problem, and to define a set of steps to work toward a solution, and then to kind of pool resources and expertise and work collectively to have that impact. And so there's other models as well. There's something called network
improvement community, which actually comes out of health. There's different ways to do it, but it's kind of a recognition that if we all are sitting and with our little hammer banging away at a big rock, but in different places, we're not as effective as we could be if we work together to bang on the same place or to bang in some collective way that's coordinated.
Yes, and so it gives you a sense for how to organize everyone together. And that's what we're looking for. Other questions?
We just have a few more minutes, so maybe a couple more questions.
Any questions? Andrew wants to know. Oh, wait.
No,
What variables are you measuring during your data collection process? Like, do you just ask someone their story and you gather data from that, or do you have like specific questions you ask and that goes into a data set? So both, yes. We use particularly, so we're also very careful about how we ask questions and making sure that that's coming across in a very way of in a very dignified way. So kind of our mission statement is love, hope, dignity, and belonging. So we make sure that all of our clients that comes first and foremost. So you have to be really careful, right? When you ask, well, what's your income? How much money do you make? Did you graduate high school? Right? Those can seem loaded, even when they're meant in the best of intentions. So we try and ask those very carefully, and there's a lot of really good tools out there, evidence-based tools. So we use a version of the American Academy of Family Medicine. It's called the Prepare tool, and it asks social determinant of health questions. So it asks things about housing and, it basically says, are you worried that you might not have enough food through the end of the month? How often do you worry about these things? So we ask those types of kind of social determinant questions. Of course, we gather demographic data, but we really focus on the qualitative stories as well. Now, when we have 500 cars lined up and we're meeting someone for the first time, that's not question number one, right? We are not like, hey, so tell me why you have to be in the food line today. That's not going to go well. But as we get to know, that's Monica's strong suit and what she does so incredibly well. But getting to know people, getting to know their story, and kind of that underneath.
Yeah, she said it nail on the head, but like we really do. So one of our things too with that starting with love, hope, dignity, and belonging is if you've ever come to volunteer in our lines, you might see like a late model BMW in the line. We don't ask them why they're there. Like it doesn't matter what kind of car you drive, we make sure that everybody is treated with that same respect because nobody wants to wait in a line for groceries because they can't afford it. And so just because you drive a nice car doesn't mean you're not struggling. I think also something to point out is like our distribution line, people start lining up the night before. So like food is a need. Houston has, so I use the term food apartheid because deserts are naturally made, but not having grocery store access is man-made. And there are plenty of places in the city of Houston that do not have access to a grocery store and they do not have access to transportation to get to the grocery store. Like I live in the zip code 77091, which is technically Acres Homes. I have a car. I have a job that pays me well. I can drive to the nearest grocery store, which is about 1 mile from my house. People who live deeper into my neighborhood and my zip code, it takes them about a 2-hour bus ride to get about 1.6 miles.
So just to add to that, some of the things that we try and do, if y'all have been watching any of the pictures go by, and you've probably seen our mascot up there. So that's Crawford, named after Crawford Street, where our building is located. But it's little things like that that we try and make it a joyful and experience as much as possible. So Crawford comes to every distribution. He's taken more selfies than you could ever imagine, and people love it. We hand out balloons to kids in line. We do, gift bags for kids at holidays. We want people to know that they're welcome, and it's not just an assembly line. So also come and volunteer.
Right, and I think just in terms of the last of the data, repeating from earlier, we're measuring access moments because that indicates how well they're connected to the rest of the ecosystem. And so trying to understand that connection, trying to understand barriers as opposed to just deficits, those are things that we do measure. So I think that that's the end of the presentation. If we may ask appropriate, round of applause for
So now that you're all so excited about that, next Saturday is our next distribution on April 16th. So we're right in downtown. We're there from 8 to 12 every third Saturday, but we always welcome. So if you want to see what this looks like in action, if you just want to come and understand what's happening, we actually always have quite a few U of H students out there. So we'd love for you to join us.
it's actually kind of fun.